Let me welcome Dr. Narmada Sharma, Chairman Scientific Committee AIOS, and Dr. Lalit Verma. Sir, please come to the podium. So there is a small change in the order of the presentation. So Dr. John Davis Sakara will be presenting about the artificial intelligence in glaucoma. Over to you, Dr. John.
Good morning, everyone. So I will start off without any further ado. Thanks to KSOS and AIOS for inviting me for this. And I would like to thank every one of the AIOS leaders for having this session here. I'm going to talk about rise of the machines, the role of artificial intelligence in ophthalmology and AI. And first of all, the role of AI is there in all our lives everywhere now. So I do not have to talk to you about the definition of AI, machine learning, deep learning. All this has become so commonplace with our phones and everything having this. We are now in the fourth industrial revolution. So after computers and automation, this is the next level. And AI is there all over the news. Even 11-year-old children are making AI apps for detecting eye diseases. So all this is there in the regular lay press. So patients will be asking us, when are we using AI? So even the big companies, Google, IBM, Microsoft, all of them have special AI teams for ophthalmic diseases. And they love to look at the retina and diagnose so many things from there, not just ophthalmic diseases, even systemic diseases. Why AI? Because it is faster, cheaper, it is very scalable, portable, it can even be offline, and there is a doctor shortage. There is a shortage all around the world, but in more so in India. AI does not rest, AI does not get bored. Will AI replace us? No, AI will assist us. Not only in ophthalmology, all the various specialties, subspecialties, everything in medicine uses AI. And why is AI very much in use in ophthalmology? Because we have lots of image data, lots of big data. We love imaging. We take slit lamp photographs, fundus photographs, OCT, angiography. We have lots of imaging systems in ophthalmology. And A scan, B scan, topography, tomography, intraocular pressure values, refraction, spectacle power, all these numerical data, visual fields. So all this data, lots and lots of data is the fodder for AI. AI best works when there is a lot of data which cannot be easily evaluated. And so ophthalmology uses AI in so many different specialties. So starting from diabetic retinopathy, glaucoma, ARMD, ROP, retinal vascular occlusions, all the way to ocular cancers. And not just this, AI is being used not only for diagnosing diseases, it's used for IOL power calculation, it's used for planning squint surgeries and planning the number of intravitreal injections which are required. So patients definitely will ask you when advised intravitreal injection, how many injections will I need? So you can give an AI powered value. See, considering your current status from your OCT, your fundus, and previous response, this is what the computer says. So that is going to help us in patient counseling as well. But not just ophthalmology. From the fundus photographs and OCTs, it is possible to detect cognitive impairment, dementia, Alzheimer's, stroke risk, cardiovascular risk. So it is not far from the future when a retinal photograph or retinal image is advised as a regular screening for all systemic health. So AI can be used so this is Google, which showed that AI can be used to predict what the age of a fundus is. And what is the gender? What is whether a retinal image is from a male or female? I think even the best ophthalmologist cannot even not guess more than 50% chance. but this is with a very high percentage of accuracy. It can guess, not guess, deduce male or female, smoking, the HbA1c value, BMI, systolic and diastolic blood pressure just from fundus images. So this is definitely possible. Eye is definitely a window into the systemic health. And of course, Alzheimer's disease, Parkinson's disease, all these affect the nerves, and the optic nerve is an extension of the brain. Definitely, all these changes will be seen in the retina. So all these, the Michael J. Fox Foundation, all these people have done studies and are making much progress in this part. Role of AI in ophthalmology is a vast topic. There is an article by us in KJO, Kerala Journal of Ophthalmology, on it. And let's just look at diabetic retinopathy. So many things, including the first FDA approved AI device, the IDX DR device. And of course, in India, we have the Medio's offline AI in the Remedio devices. And then AI can be used to generate retinal flow maps from just the structural imaging. And so much enhancement of low quality images. So if we have AI, with the help of AI, we can get lower cost imaging and scanning systems. If you want to try AI, this is one of the places where you can do a free AI evaluation of fundus images. Just make an account in Orbis CyberSite and then upload your fundus images. Glaucoma, of course, all the OCT segmentation is AI that has been there for years together, but the Sensimed Triggerfish IOP measuring contact lens, the IOP values were obtained by using AI to extrapolate. And fundus, detecting the cupping of a fundus image. That is a very regular engineering college topic. So very, very commonly used. All engineering students love to do AI in ophthalmology. Glaucoma also, there is a lot of visual fields related stuff. So detecting pre-perimetric glaucoma from perimetry. So pre-perimetric, the definition means it is not shown in perimetry, but you can do that with AI. And of course, various different types of visual field defects can be detected, but AI can also predict the future. So if you have a patient and you tell them, see, this is you today, and if you don't use the medication correctly, if you don't get the surgery done soon, this is what you're going to be in 5 years. You can predict the visual field progression, and up to 5.5 years progression was predicted by this group by actually feeding in 32,443 visual fields to the machine. So now that machine can tell you at various IOP levels what will be the future. ROP, lots of software available to detect the ROP, and age-related macular degeneration, vascular occlusions. I'm skipping through this because there's a lot to know. Just have to know that every corner of ophthalmology is touched by AI. OCT, everything can be detected by the software, and every kind of disease of the retina. Keratoconus, you can identify form frustrate keratoconus. You can predict the future of not only keratoconus, and you can also predict diseases from the confocal microscopy. You can predict cataract from regular photographs. This is another student project. They take photographs and detect cataract from it. The app is available. I think it is given an appreciation award by the government of Kerala recently for a student app for detecting cataract. And this is not just in, the whole thing. Pediatric ophthalmology, lots of things starting from predicting the myopia. Like you can predict the future progression of myopia. You can detect leukocoria from regular photographs. You can plan the surgical resections and recessions. Ocular oncology, you can detect the margin of the OSSN without even staining, because there are microscopic changes which cannot be identified by the human eye. And of course, refractive error, as I said, progression of myopia can be predicted by using various factors. So you'll know when to start for treatment of myopia. I'll just quickly finish this also. So AI is not just in the treatment and prognosis. You can have AI for low vision patients. So Google Lookout app is one app which can be used by low vision patients to just move around, to read things, to detect objects, to count currency, so many things. And there's also the Microsoft Seeing Eye app, Seeing AI, that also does the same things. Then Be My Eyes, Iris Vision. So Iris Vision is a device which uses AI to convert images into something which can be easily visible by patients with ARMD. So all these things are also there. And the assistive wearable devices, including the Orcam My Eye, the smart vision glasses. But we should be careful. AI can make fake retinal images. It can make fake lesions on the retina. AI can generate images by itself. AI can cause so much havoc if not used correctly. So all the hacker attacks on medical devices is a very, very true thing. Thank you.
Thank you, Dr. John. That was an excellent presentation. And next, may I call upon Dr. Namada Sharma. So there is no need to introduce Madam. She is a scientific committee chairman of AIOS. So she'll be talking about biosynthetic cornea, the new frontier. Welcome, ma'am, to the Drishti 2024, and over to you.
Thank you, and I would like to thank the Kerala State Ophthalmic Society. Is it coming? No? Zoom Mac connector. It's not getting up. Settings. To decrease not happening. So should we ask somebody else to present? Can I present? Even with this, I'll airdrop. Where is the airdrop? I would be talking to you about the biosynthetic cornea that we are working at. And the major causes of blindness in our country is cataract. And if you see in the age group more than 50 years, it is corneal opacity, which is the second commonest cause. And if you look at the age group less than 50 years, it is the commonest cause of blindness in our country. So there is a need for biosynthetic corneas, mainly because of the limitation of the human donor corneas. And what we've worked on is the bioengineered porcine construct double cross-linked cornea, which we called as the BPCDX, which is obtained from clinical grade collagen, type 1 collagen, obtained from the porcine skin, and it is doubly cross-linked using cross-linking agents. It essentially looks pretty much like a soft contact lens, except that it is slightly rigid. It comes in thickness of 100 to 500 microns, and the shelf life when in the bottle is 2 years. And it has been made according to ISO and GMP manufacturing and packaging processes. It has undergone all the quality checks, which include the biological safety, the in vivo biocompatibility, the in vivo evaluation, and the ex vivo analysis in the animal model as well. Now, if we compare it with the native porcine cornea, then the fibrils tend to be a little thicker, and also the space between the fibrils is wider. And if we look at the histopathology, then this is the intrastromal implantation of the biosynthetic cornea, which looks acellular, but it integrates well into the tissues where it is implanted. And this is the native porcine cornea, which has cells, and so there's very little difference between the two of them. We use femtosecond laser to create the pocket, but we can use even, you can create the pocket manually also. So with the help of the femtosecond laser, a pocket is created, so much so that the recipient residual bed thickness should be 100 to 120 microns. So you can do it in very thin corneas also. And this pocket is opened first with the help of the, it is opened first, followed by the lamellar dissection, which is done with the help of the lamellar dissector. And this is a biosynthetic cornea which has been triphonated in the same dimensions as the pocket. And this is subsequently implanted intrastromally, and then it is unfolded in the intrastromal pocket, and a bandage contact lens is then subsequently applied. So you don't have to apply any sutures. This is how it looks on the post-op day 1. So this can be seen sandwiched intrastromally, and this is the bandage contact lens over it. This is the second case, keratoconus with pellucid marginal degeneration, and so the thinning is going right up to the periphery. And in this case, again, the pocket is created. So the pocket becomes a little eccentric, and it has to go right up to the periphery, because that is the area which is the thinnest part. After creating this pocket, the lamellar dissection is then done just to reinforce the same pocket after opening it from the superior side. And subsequently, again, the biosynthetic cornea can be implanted in the intrastromal pocket. And this is the intraop OCT microscope, wherein one can see that it is being implanted intrastromally. And this would go right up to the edge, because the thinning part is present right up to the edge. This is followed by a bandage contact lens application. Now, this patient also had cataract, so 3 months down the line, the cataract surgery was also done. And the only thing that you can see is the rim of the biosynthetic cornea, and otherwise the media is very clear. This is the same case which we showed just now. This is the third case again of keratoconus, again where biosynthetic cornea has been implanted, and the K max from 85.9 diopter decreased to 57.1 diopter. And if you compare, this map has also become more regular. This is regular astigmatism as opposed to this, which has a large keratoconic cone. This is our longest follow-up, now over 7 years. So what eventually happens is that there are some deposits which are seen at the edge of the synthetic implant. Apart from this, it remains fairly clear, and this is very much the type of deposits which are there when you do implant intacs. This is a case of post-LASIK ectasia, where the flap was elevated, which had previously been created, and subsequently the pocket was reinforced all around so that you could implant the biosynthetic cornea there. The synthetic cornea was then triphonated, was placed onto the bed, onto the stromal bed, and the flap was then placed over it, and so again you can see that this is sandwiched and this is markedly thinned out here, which possibly is also the reason why the ectasia occurred. And then sutures are applied because the flap is edematous, so it will not hold on if you just leave it like this. So the sutures are applied, and notice there's so much of thinning. Now again, the keratometry here, which was 89.2 diopters, decreased to 50.4 diopters, and pachymetry increased from 241 microns to 581 microns. And again, if you see, the astigmatism has become fairly regular, in fact almost completely gone. In cases where there is haze present, there it may not be possible to make a pocket with the help of femtosecond laser, because it will not penetrate. So a microkeratome is being used here to dissect the anterior part, which is hazy. Some amount of manual dissection was also required here because the microkeratome did not reach up to the hazy part of the cornea. And then subsequently the biosynthetic cornea is taken, is triphonated, and is placed onto the recipient bed, and then it is sutured with the help of the fibrin glue. Subsequently then a bandage contact lens is placed over it, and this would take some time to epithelize because there is no epithelium over it, unlike intrastromal keratoplasty, but does epithelize well and does clear up, although this takes about almost 2 weeks to epithelize, for which you have to place the bandage contact lens. If you see anteriorly on confocal microscopy, you can see the nerves, and posteriorly you can actually also see the endothelial cells which are present surrounding the biosynthetic cornea. So this is a little far-fetched, but I think in times to come, this is something which we are envisioning, that we don't require preservative media or the eye bank or the eye bank personnel or the eye bank paraphernalia. If you can also grow endothelial cells on this stromal construct. And our results, along with the results from another cohort in Tehran, were published in Nature Biotechnology, which has an impact factor of 68.1. And this essentially came out from the study which was done by Dr. Meherdad Rafat in Sweden. We've now done this implantation in close to 70 eyes, and there are no rejections, inflammation, vascularization, or scarring in any subject. And the longest follow-up we have now is 7 years. We also compared the intrastromal keratoplasty using human donor cornea with the biosynthetic cornea, and we did not find any difference in the best corrected visual acuity. However, pachymetry was thicker with the biosynthetic cornea than with the human cornea, because once you implant human cornea intrastromally, there is some amount of attrition that would occur over a period of time. Also, the central corneal thickness was greater in biosynthetic cornea than human donor cornea, and this is just to show the biosynthetic cornea and the human donor cornea, which does thin out over a period of time. Astigmatism, both in terms of the refraction as well as Kmax, was same in both the groups, and there was no difference between the two groups, and so also the higher order aberrations. It is feasible to distribute these corneas. It is not dependent on human donation. It is a simple surgical technique. There are no graft rejections and failures, suture-related problems, and perhaps eye bank facilities minimally involved. And in the event of a complication, although we didn't have any in our cohort, it does not preclude a human graft transplant in the form of deep anterior lamellar keratoplasty. Now, as a further prelude to this, we are trying to grow endothelial cells on this, and this is a project which has been approved by ICMR, and I think when we have that, then we will have a complete corneal construct. So, use of bioengineered corneas for intrastromal keratoplasty is a feasible, safe, and simple technique for corneal ectasias, and tectonically they are better supported when you compare it with the human donor corneas. And I think this is going to be the future, when you just open the bottle and use these synthetic cornea just like you do with intraocular lenses, without having to depend on human corneal donation. And I would like to invite all of you to Asia Pacific Academy of Ophthalmology, which is going to be held with AIOS at Yashobhumi in New Delhi, April 3rd to 6th next year. And Dr. Lalit Verma, who is also the Congress President, is also with us here, and I'm sure he will also invite you for the same. Thank you very much for your kind attention.
Thank you, ma'am. We will have the discussion towards the end of this session. Now I invite Dr. Lalit Verma. Dr. Lalit Verma is the past president of AIOS and president of APAO Congress 2025. He is the Secretary General, South Asian Academy of Ophthalmology and Director, Vitreoretina Services Center for Sight, New Delhi. He was the General Secretary of AIOS, Chairman Scientific Committee of AIOS, and Chief Organizing Secretary of 15th and 16th SIO Conference. Over to you, sir. Today he'll be talking about vitrectomy in PCV.
Thanks a lot, and thanks to AIOS Scientific Committee, Dr. Namrata Sharma, for conceiving this unique program that she does AIOS Scientific Committee session in all the state level annual conferences. And thanks to KSOS also for agreeing to host this program. So, as Namrata has already said, APAO is a big event, and all of you should try to come there. This is being held in Yashobhumi, one of the largest convention center which largest in the Asia, and this event will be part of 83rd celebrations of AIOC and 40th APO conference. And all of you should try to come. In case of difficulty, you can directly contact also, either me or Namrata. So we'll be talking of IPCV primarily. IPCV is one pathology which is actually not ARMD, which is a different pathology, because you do not get colloid bodies of drusen in this. And most of the times, if media is clear, you tend to do monotherapy today with anti-VEGF agents, because previously we used to do PDT with vertiporfin, but vertiporfin is now not easily available. So primarily treatment is on anti-VEGF monotherapy, either with aflibercept or with newer agents, abrolucimab or even faricimab also. But once these polyps bleed or trouble, then you can have massive hemorrhages. So the diagnosis also is generally when there is a large subretinal hemorrhage or large exudation in the macular area. In the absence of any colloid bodies, we start suspecting this could be an IPCV. Previously, ICG angiography was the hallmark in diagnosis, which still I think is a gold standard. But now a lot of criteria on OCT by Girdhar Group and others also have been listed, where you can diagnose IPCV with reasonable sensitivity and specificity also. But I will not be talking of anything about anti-VEGF agents in IPCV. I will be talking of complications which can sometimes happen in a patient of IPCV. Patients sometimes can present with vitreous hemorrhage and submacular hemorrhage. Other causes of submacular hemorrhage include ARMD or a ruptured RAM, retinal artery macroaneurysm. So at the outset, any macular hemorrhage not for retina people but for comprehensive ophthalmologists is not the same. You see, always you should try to see the relationship of hemorrhage with the vessels. In case vessels are overlaying the hemorrhage, then it's an emergency of the eye. It's an ocular emergency, in fact. After trauma, central retinal artery block, I think this is the third emergency which should be addressed on a war footing. And if you cannot see the vessels, that means the retina is behind. That means it's a subhyaloid hemorrhage. And this can be watched or sometimes, operated with reasonably good prognosis. There's no hurry to, intervene in such. But this bottom figure is as I said, ocular emergency. And if prompt action is not taken, then you can have a big macular scar. And the reason it is emergency is that there are a lot of things responsible. Because remember, the hemorrhage is in between the rods and cones and the RPE. So if the hemorrhage is there, fibrin will, contract and destroy the photoreceptors. And iron liberated is also toxic to the circulation there. And also mechanical barrier between mechanical. But the main factor which I think is the contracting clot, which damages photoreceptors and ultimately leads to a scar. And that's the reason aim is that this hemorrhage should move from the macular area to somewhere else. So that is the whole aim of treatment. Because from an important seeing area to a non-seeing area, that is the whole aim of. If it's a very fresh hemorrhage, you could inject some gas and it will move. but by and large patients present late and becomes a clot. Clot mechanically difficult to displace. So we'll just discuss about how to manage this. If left alone, as I said, irreversible damage primarily because of the damage to the photoreceptors, and that's the whole concept. So I'll describe only 3 scenarios here. One is a small thin hemorrhage like this, which generally OCT picture is very typical here of IPCV, and you can see this this amalgam here is the hemorrhage here, which I am pointing with the help of arrows. Such hemorrhages generally do pretty well with anti-VEGF monotherapy. And this is the patient where we have injected 2 injections of aflibercept, and you see doing pretty well. And this is the corresponding OCT at presentation, the bottom figure, and later on after 2 injections. So another patient who has had the presenting vision of 636 and the OCT picture like this, and after 1 injection only, this patient did a response. Meaning thereby if a small hemorrhage, thinner hemorrhage, you can do away with only anti-VEGF. Another example of this patient. One more example, small subretinal hemorrhage here, submacular hemorrhage in fact, and this is the OCT, a dome-shaped OCT, and this above the OCT you see this is the hemorrhage, this area. And after 1 injection, how this has responded. It may require 2 or 3 injections, like in this patient we gave a 2nd injection again, and you see from 1st, 2nd, 3rd, it has, the hemorrhage part has gone down. So this was scenario number 1, where the hemorrhage is small and thin. Scenario number 2 is something like this. It's occupying a bigger area, it's a thicker hemorrhage. So in this patient, what generally we do is a pneumodisplacement. Pneumo means you inject, pneumo means air or gas inside the eye, and position the patient so that the mechanical effect of gas is to displace. And this is how this patient behaved. Under topical anesthesia, only 0.3 cc of C3F8 along with the aflibercept, because aflibercept is required because that treats the cause, whereas gas will mechanically do the job. And this was the result of this patient. And after the hemorrhage moved, then we did angiography studies to find out from where the blood came. And if you can identify polyp or some leaking area, then you can laser, so that is the end of the treatment. So here we found this extrafoveal leak, and we lasered with the focal laser. So this was the nutshell at presentation, and after 2 weeks of gas injection, this patient did pretty well. This was another patient who had in the left eye, where pneumodisplacement was done. See, it's a dark colored hemorrhage. So initially I was planning that we will do subretinal TPA, but patient, because it was next day was Sunday, we could not do it. So we just injected gas on the same day, and we saw him, and the gas had done the job. And this is the corresponding OCT. If you see from the lower figure upwards, this patient has done pretty well with the pneumodisplacement. So pneumodisplacement of a subretinal hemorrhage works pretty well in a moderate size hemorrhage, and it's a cost-effective technique because not a lot of consumables are used, and patient generally agrees for treatment pretty fast. But caveat is it should be done pretty early in the course of disease. The last scenario is something like this, which is very, very scary, and it occupies the entire posterior pole. In this patient, possibility of gas working is pretty low unless it's a very fresh hemorrhage. Generally, these hemorrhages are pretty old. So this was a lady who presented like this. Left eye had some evidence of macular degeneration. This was the corresponding ICG, which revealed a polyp in the right eye as well as BVN. Left eye essentially was okay. So we planned for vitrectomy, counseled the patient the need for subretinal TPA. The issue is that subretinal TPA is an expensive injection, costs nearly 18 to 20,000 rupees, and hardly we use 0.05 ml. The rest of the 20 cc goes waste unless there is some other patient. So this was the surgery where a routine pars-plana vitrectomy is done, and then after you have removed the hyaloid face, then what you do is this dual needle, where this is the tricot inserted to take care of the hyaloid, and once the hyaloid goes away, then this syringe, which 23/41, that means the insertion is to 23, but there's a long needle of 41 gauge, where generally where there's such a large massive hemorrhage, we insert at 2-3 locations. One location may not, because I believe there are loculations here which cannot. So this is the second area which we are injecting, subretinal TPA. And after you have done at 2-3 locations, Even if some regurgitation occurs, it generally does not matter quite. So after that, you do a air fluid exchange and then come out of it. So this was the pre and post of this patient, immediate post-op period, and 1 minute I will take here. And this is the long follow-up also. So this is the sequential timeline photograph of right eye, first photo follow-up, then subsequent follow-up. Doing reasonably well, vision recovery also and anatomically also. This was a medical doctor, in fact, who presented with no glow actually, no glow, and on ultrasound we could find some mound in the macular area. So this was the vitrectomy here. You remove the intragel hemorrhage first, which is behind the lens itself, and once this intragel hemorrhage is taken care of, you find on the posterior pole large mounds of black-colored subretinal hemorrhage. And you can see the relationship of vessels with the hemorrhage. It's a large subretinal hemorrhage which will require TPA. So we had counseled this patient that you may require. So again, after this PHF has been taken care of, you poke with the help of needle. There are various ways, either mechanical injection or also you can inject this with the machine also. You see, so as to not to have jerky movements. So this is showing some people combine it with air also, some people combine it with fluorescein, a lot of things have been used. So this was the first post-op day of this patient, and this was the largest follow-up after. Thanks to the health of optic nerve and the macula, this patient recovered excellent 6/6 vision. So had we not acted, on a war footing, this patient would have landed up in hand motions or PLPR kind of vision. So thus to conclude, always remember all macular hemorrhages are not the same, and hemorrhages like this, thin hemorrhages can be dealt with anti-VEGF alone. Moderate size, you require nemo displacement plus anti-VEGF, and large size require hyaloid peel, subretinal TPA, gas plus anti-VEGF. Anti-VEGFs are there in all the things because anti-VEGFs have to treat the cause, whereas other things are just mechanical to displace the blood or dissolve the blood. So again, this slide to request you to please join us at APO in first week of April. Thank you so much.
Thank you, sir. Now, may I call Dr. Sharavanan? Yeah, Dr. Sharavanan will be talking about latest advances in retinal imaging. Over to you, Dr. Sharavanan.
Thank you, sir. Thanks for the opportunity to have me here. Since the invention of ophthalmoscope by Babbage and Hermann von Helmholtz, a lot of things have happened in the field of imaging. So once the direct ophthalmoscope, we were able to see only the disc and macula, and very difficult to see the periphery. We have considerably moved from that scenario to the current generation Optos 200-degree imaging with using the. Here you can see that this is the founder of Mr. Douglas Anderson, and his son had a pediatric retinal detachment, and because he felt that the children were not very cooperative for indirect ophthalmoscopy and it was being missed easily, so he planned to devise his own fundus camera which will enable pain-free and glare-free imaging of the retina. And this is his son when he developed the RD at a very young age group, and this was the first prototype of the current Optos machine. And it's a pseudo-color imaging, it's not a true color, but it gives you a very good view. And this is currently the now in thing which is happening in the field of retinal imaging, that is almost pan-fundoscopic imaging or a wide field fundus imaging. So you have other current channels which can help you to visualize various layers. There's a red-free channel, and then you have the choroidal channel, and also the autofluorescence, which kept especially very useful in inflammatory diseases as well as slow progressive degenerative diseases also. And also it can perform wide field fundus fluorescent angiogram, and so henceforth we are not aware that diabetic retinopathy can have peripheral ischemic areas which can be a cause for NVA as well as persistent CME. All these have been easily captured with the Optos imaging. Now we have a so-called peripheral disease. Now a new term has been introduced for the diabetic retinopathy where you have peripheral disease also. We have that new finding also which is coming up. And also the wide field indocyanine green angiography can pick up again a new disease which NTAT, which is peripheral exudative hemorrhagic chorioretinopathy. All these were new terms which have been introduced because of the wide field fundus cameras. We have been diagnosing new things. And also a very nice way of documenting things, especially in the small people where even indirect ophthalmoscopy is not very easy to perform. This can easily capture the various peripheral changes. Here you can see previous was RD, and here settled retina because of a buccal surgery. All this can be very easily captured. And also, as I told you, this is very since the advent of FFA by Dr. Novotny and Alves. So we have come a long way. So originally the fundus camera-based systems had a lot of limitations in capturing the periphery as well as the brightness, whereas now the confocal scanning laser ophthalmoscopy-based cameras, which can capture much more clearly as well as much more wider field. And you can see the difference between ICG angiogram captured by the routine camera-based system and the CSLO-based system. You can easily define the polyps and the branching vascular network, which is very subtly seen in a camera-based system. So all this is giving you much more depth, clarity and depth imaging of the various layers of the retina. Again, showing the difference between the FFA and ICG. The same patient, you can see the FFA is capturing the classic network seen in the superficial layer, and in the ICG you can see the deeper type 1 component, which is it's a combination of type 1 and type 2 CNM, and both the FFA and ICG are capturing both different parts of the same disease. The deeper and the superficial layers captured by the FFA and the deeper by the ICG. Again, as I told you, this is the FFA showing peripheral disease. You can see the presence of, normally we till all this we are only aware that the new cells happen posterior to the equator, but now we are seeing that NVs can develop and ischemic zones can develop outside the equatorial zone. This is the area which can be conventionally captured with a routine fundus camera, and this is the comparison to the large wide area which is being captured by a Optos camera. Again, seeing the peripheral disease very critically, which is can be easily missed in a routine camera-based systems. So because Optos gave a pseudo color, then there have been new set of cameras coming up, wide field cameras coming up, which can capture true color imaging. So this is a comparison to a traditional fundus imaging and the true color imaging of the Zeiss and other IDON. So there are a few cameras which have come up with it can capture true color image. So we are now used to viewing the true color images. So when you shifted to Optos, we are a little bit difficult diagnosing the various lesions, but now we have cameras which can, but unfortunately they can capture only 100 degrees, but you have to take two fields to fuse it to give a equal to Optos image. Field equal to Optos image. Again, this also has various channels to visualize various layers of the retina, and also the autofluorescence, which is very important. And again, the FFA, unfortunately, ICG is not available, only FFA is available. In the OCT things, again, we have been seeing the difference between the the time domain and the spectral domain. Also, we have the handled OCTs for pediatric imaging. So by stabilizing the reference mirror, we've been able to capture, this is the old time domain, see the clarity of the image, and the newer spectral domain where you can see the various layers very easily. And this is a leader to, it is almost like a histopathological section of the retina, which can where you see the various layers and correspondent to, so that you can diagnose which layer the disease is affecting that patient. Just showing some examples here. This is a case of a glaucoma, and you can see the nerve fiber layer where there is the so-called sectoral loss of the RNFL, and you can see the multicolor image also picks up that very easily, showing that RNFL loss in that particular inferior notching area. So again, it also gives up the various layers of the ganglion cell layer as well as the nerve fiber layer. Especially this is very helpful in glaucoma and in optic nerve diseases. Just showing a patient of optic neuritis here. You can see right eye is normal, left eye is having a disc edema. When you see the compare the RNFL, it is normal because RNFL loss happens much more later. But when you see the RNFL, you can see it's only the edematous RNFL, not loss. But when you see the GCL, you can see the loss of GCL, indicating that it's optic nerve disease and this optic neuritis. Even though the RNFL is thicker, you can see the GCL thinning is happening, indicating that this is definitely an optic nerve disease, and this was diagnosed with multiple sclerosis and treated with steroids. And again, we have the swept source OCT giving a much more wider and also inner depth. The choroid layers can be very easily seen, so the new pachychoroid diseases can be easily visualized with the swept source OCTs. And the current Opto Silverstone can visualize almost 23 millimeters of a wide retina in a single cut. And now we have prototype machines which can capture from aura to aura the OCT of the retina. So probably in coming years we'll be seeing that. Again, we have the OCTA compared to the FFA. So you can see the layers much more easily, the network vessels. And you can see the, especially for a diabetic patient who has macular ischemia, it's very critical. We can do OCT and diagnose the loss of capillaries in the posterior pole, as well as just showing a patient with the patient had a cardiac arrest recently, so we could not do FFA, but you can see that the OCT can pick up the NVD and the NVE. Again, this can be done in critically ill patients where FFA is not indicated and not contraindicated. And again, this is a patient or a doctor actually who was diagnosed with CSR and undergone 2 sittings of focal laser with no response. And here you can see the fluid here and the small PED which is there in the subfoveal zone. So we had some suspicion that it could be a pachychoroid neovasculopathy, and you can see the OCT is picking up the pachychoroid neovasculopathy. And now we have revised the diagnosis and we can inject anti-VEGF in these patients to treat this disease. So this is a superimposed image of the OCTA on the color fundus photograph. So now also we have the artificial intelligence in the imaging field. So nowadays what we are doing for data in our hospital, diabetic retinopathy screening has been totally automated by using the artificial intelligence. So our address system or the Arvind diabetic retinopathy screening IDC screening systems, which address system, which now we are using only, no doctors are doing the screening, only the AI is doing. So 19% of the work is done by the AI, thereby obviating the need for loss of doctor manpowers. I'll stop here and thank you for your attention.
Thanks, Ronan, for excellent images. Excellent images. I wish we could have gone slower and seen all the images very carefully. But I think it's lecture worth repeating also at some other forum. So now we'll have Dr. Ganesh to talk on we have covered cornea, retina, glaucoma now. So what is new in the management of glaucoma?
Thank you, sir. At the outset, I'd like to thank the chairman of the AIOS as well as KSOS for providing me this opportunity. I'll be speaking to you on what's new in glaucoma therapy. So as you know, you have a lot of glaucoma medications. You have aqueous suppressants, medications reduce EVP, increased trabecular outflow and increased uvascular outflow. But what's come new in India, and it's I think we should be proud about, is because it's manufactured by an Indian company, is the triple fixed dose combination. So the rationale is you have 3 medications which have all 3 components, and the main advantage, as you will see, is that the compliance and the BAK and all reduces. So this is the first clinical trial on fixed triple dose combination known as TriSopt by the, I don't have any financial disclosure, as I mentioned before, it's by the Microvision company. And it was a nice open label multicentric, and we all participated in it in a phase 3 trial. And you can see from the pressure of 25 millimeters of mercury, The intraocular pressure at 12 weeks became 15 millimeters of mercury, and a lot of people using this medication, including patients, are very, very happy with it. So you can see almost a 10 millimeter drop. So these patients at 25 millimeters of mercury were already on combination of timolol, brimonidine, or timolol dorzolamide, and then the triple medication was added. So the side effects are also very, very extremely less. So it has a complementary mechanism of action, better compliance, reduced preservative exposure, and efficacy, safety, and tolerability is quite superior. So this has now become the almost go-to drug, because all the three molecules can be used in all forms of glaucoma, not just, just open angle or angle closure. Even in inflammatory glaucomas, you could use this. Now coming to other set of groups of medications. In India, we always have multi-dose vials, whereas abroad you get all these unims. And so now the drug delivery systems have also improved. I'll just show you two of them. So this is the Aptar ophthalmic squeezer, which is commonly used by the Cipla company. So the drop is actually a defined size, and it has a dual channel system to release the drop from the tip. Sorry. And there's a sealing membrane which opens up to allow the liquid in the dual channel to pass from the tip, and then the air intake is permitted through a 0.2 micron sterilizing filter. And the drop comes out, and this is the mechanism. So the drop comes out and is compensated by the air, but which goes through a filter, sterilizing membrane filter. So this is something very, very important. Secondly, again, we have the Novelia bottles, which are commonly used by other companies, and the nozzle selection is about 28 to 46 microliter, and drop size, viscosity are standardized. And upon exit of the drop from the bottle, the exit valve closes and air intake occurs. So why we are talking about this is, when you do a phase 0 trial on animal studies, you use preservative-free medications. But when it comes to humans, you add preservative and give the medication. So that's quite a paradoxical thing. And those patients have to use it for almost 30, 40 years of their life. So these are something which we should incorporate. And preservatives like BAK, what exactly they are? BAK is 0.02%. Your Harpic contains 10% of BAK. So what you are actually putting in is your Harpic into your eye, And then coming to the technology and the glaucoma screening, if you see, we have a good way of taking, screening for glaucoma, and in our clinics we have this opportunity screening. So for both for open angle as well as angle closure, there's a series of publications, and now we are in the last trial where we are screening almost 30,000 patients, and asking their relatives come for follow-ups and get screened for glaucoma. And if you see the incidence, so if you have a patients with open angles, and their siblings will almost less than 10% may have their siblings will have angle closure or angle closure suspect. Whereas if you take the PACS proband, you'll have a significant number of their siblings with PACS. And if you see a PSC proband, whose patient sitting in front of you, he's got PSC or PSCG, you'll find that significant number of their siblings are likely to have angle closure. So that's something which you have to think of. You see angle closure glaucoma patient, make sure that they are screened, the family members or their siblings are screened. Similarly, if you have a patient with angle closure disease, their siblings are likely to have twice the number of chance of having angle closure glaucoma compared to a patient with PACS. So that's quite significant. So laser devices are again something which have come in now, and we are using this quite commonly. So you previously had the flash pumped diode laser, so it would function as a photo disruptor. Now you have the diode pumped neodymium orthovanadate dual function lasers, and I won't go into the results of it. I think you could, as the results come out, you can read it in the publication. But the advantage of this is you can cross-subsidize these lasers. So you have, on the left side, you have SLT with photo disruption, and these are the companies which manufacture and sell it in India. On the right side, you have photocoagulator, and these are the ways you could use this laser to cross-subsidize your SLT. So it's a win-win situation for both all type of ophthalmic patients. Minimally invasive glaucoma surgery are numerous, and you have huge advantages, and now it's a go-to procedure for glaucoma, for mild to open angle glaucoma. Nice review by Dr. Vanita Pathak about minimally invasive glaucoma surgeries. And these are the types of devices which we have. and they are more physiologic. So you have the KDB device, and then you have the iStent devices, and then you have the Tanitos microhook, and then you also have the GAT procedure. So all these devices are quite useful. They address the main problem in glaucoma surgery, which is the trabecular meshwork, and more physiological, and you have options of doing repeat surgery or the conventional glaucoma procedures later on in the patient's life. So the idea is to reset the AGM clock of the patient. The patient, if he has to use glaucoma drops for, let's say, about 20 years, 30 years, if you do any of this, you're taking away 7 to 10 years of their life on medication. So I'll just talk about this lady. She presented to us in 2022, and she had phthisis bulbi in the right eye, and she was on 5 drops, juvenile open angle glaucoma patient on 5 drops, pressures of 42, and vision of hand motion. She was referred to me to do a diode laser for the seeing eye with a vision, because everybody gave her a very poor prognosis. So I did a canaloplasty for her, which is of course not a minimally invasive glaucoma procedure, but is very useful for her. And slowly, if you see over a period of about 1 year, the intraocular pressure remained flat, and the visual acuity improved from HM to 5/60 and 6/60 thereon. In this situation, she traveled from Raipur to Gujarat, from Gujarat to Delhi, and then she took almost 5,000 kilometers to reach us. So although we have a lot of technology and a lot of scientific content behind our, we still need to, as glaucoma surgeons and ophthalmologists, put ourselves in the patient's shoes and see how we can improve their lives. Thank you very much.
Wonderful presentation, Ganesh. A lot of learning, in fact, about this. Last slide was quite emotional also, and but very good that from hand motion to 660, you made this lot of change in her life. In fact, yeah. Otherwise, you see such people may develop suicidal tendencies. In case you have PLPR or hand motion vision for a long time, young girl. Excellent job. So, after a lot of wonderful talks, I think must congratulate Namrata on this. On AI and latest in imaging, biosynthetic cornea, and new in glaucoma. Now we'll talk of something which I think concerns everybody, which Sharad Babu is the master of that, is how to maximize your worth.
Yeah, hello. Thanks to Kerala Society and also the AIOS for giving me this opportunity. Here I am to discuss about the worth of our individual and the practice. Individual, again, we have to talk about more about the spiritual level, which we can discuss later on during the lunchtime. But now I'm here to discuss about the worth, how to create your worth in your life. So this is a story which I am telling about me, which happened by itself, but at the end of the 25, 27 years, I understood how I could create worth for myself, and then what I am doing right now. So I was there practicing in a small clinic, in a 2-room clinic in 1993, started my practice in a small place called Warangal near to Hyderabad. And then I got married, I got twin daughters, and then I had to really spare some money to invest on the equipment, at the same time to take care of my family too. And 2 daughters, you know them. And of course, in then 1995, started with operating a phaco surgery, because it's very expensive that time. When I bought the machine, Alcon Universal one, I was told that I could get a very good land in Hyderabad for that price. That's 8 lakh rupees I spent on one machine, which was really very difficult for me to buy that. And then I went for a loan, and then the same, if I have bought the price, the land then in Hyderabad, that would have been given me 200 crore rupees of worth land that time. But then, never matter. I tell you how to create worth now. So then the passion for the academics, and then it keeps moving you to the higher level, like you keep buying equipment, go to the next level equipment, enjoy the surgery, doing good to the patient, and then patients keep coming back, asking you to do much better. and then you keep go on and on, then paying these guys, these surgical equipment guys, the money, their maintenance contracts and all that, and then it still goes on like that. So the Catalyst, the Varian, the Centurion, and and everything. But then what again now? See, you keep doing lot of surgeries, then you have lot of data, then you want to tell somebody else what you are doing, so you search for the podium, and then that's how you go into the associations, our professional associations. I come from Telangana, so, and earlier Andhra Pradesh, so go into the podium, then go there as a member, as a managing committee member, and then go to the higher level, then go to the scientific, and then keep presenting papers, and then what you are doing, how your new equipment is working on our patients, and then go to AIOS, and then go to those podium, and then keep talking, and then go for the again for the elections there, and then win something, and then go to all the places, and then it keeps on growing. Like now you meet people all around in the different states, and then different podium in different levels, and finally I was invited for the worth talk now. They have been talking about cataract and glaucoma, even though I keep doing now even 20 cataracts in a day, every day. And then now what happens? Now you get associated with too many societies. Like, even though I'm a phaco surgeon from 1995, I still do SICS, so you get adjusted to the different associations, the ACAIN, and then, but somewhere you have to let it go. So some spiritual master says that, which got into my mind, you have to give back to the society. What you have got it, you have to give back at least a portion of it, either some money or give time for that. So that's how I started some camps doing there. There is another background which I have to tell. I am new to that place where I started my practice. I want myself to known to everybody. So also I started doing that. And then suddenly one NGO comes there and then says, hey doc, we want to get associated with you. We are there only with Shankar Netralaya, L.V. Prasad, Arvind. But we saw that you are only a private practitioner, single man practitioner, but we want to get associated with you. That's the Operation Eyesight Universal. Then we started doing some camps in and around, taking some 40 villages around and then doing some camps. But then suddenly one private bank comes and then says, the chairman comes and then says, doc, we want to get associated with you. The 16 villages we have, you please take care of the farmers doing subsidy surgery for this place. So I started doing there, and then suddenly he comes and says, it's very difficult, doctor, to bring all the patients to your hospital. Why can't you start one small clinic in my place, which is around 32 kilometers from my place? I thought, why can't I do that? But I don't have any doctor, so I started a small clinic there with the optometrist. So that's how the vision center concept came into my mind. That's where I was going around searching what is this concept, and then going to Arvind, seeing L.V. Prasad, what they're doing. And then I started getting both of them together, and then come out with a very good vision center concept, and then started one, then two, then 8. Now the Rotary International also sponsored 2, and then we have 8 centers, but I have a plan of starting 54 centers, and that is going to become reality in the next few years. Of course, then the ACAIN, the community ophthalmology, but then you should be again a part of the IMA also, because that's a sister community where you get to know more about they come to know about you. That's how you come to know, being a part of that, and then the president of the state, then the AIOS I was telling, then a local hospital also, the bigger hospital like the regional hospital, you get attached to that, be a member there, and then be in the private bank, go there as a member there. They invite you, you be there, know about the banking system, how it is working, and then start the vision centers at the same time all over the area, adopt some villages, start working there instead of working here and there, and then make them avoidable blind-free villages. And this is where the actual worth comes in. See, you keep doing this, the community work, that's where the recognitions come in. You keep bringing patients, operating them, and then sending them back. And a lot of surgeries been happening, and this is being recognized all over the place. So you get recognitions. These are the different vision centers. We start the refraction, cataract, glaucoma, and everything, tele-ophthalmology. And then we decided, okay, there are so many vision centers, patients have to travel a lot, let me establish 2 again secondary centers. That's how 2 secondary centers have come, and now the vision centers are all around. So the practice has increased. Now it's a 36,000 square feet a hospital I am having. Now what to do? Now what is that is, now I know that I am nearing 60, I can't live long, but my surgical skill I want to give it to the young generation. That's how the training program started.
Dr. Sharath, actually we are running short of time. Can
Yeah,
you
I'm
just
finishing.
yeah.
So that's how it started. Then the all these awards come to you. Now what? Now maximize your worth. What to do that? So you have a potential. You have to get accustomed to yourself to the society. Let the society know more about you. It's not only the society, but to see your worth, you have to maximize and then join a bigger institute. That's what I've done. Took some money, and then being a passionate ophthalmologist, I still work. I then be a part of it. So these are the things which you need to know and then do it in your life, and definitely it's worthwhile. Your life will be worthwhile, having a peaceful life afterwards, having money at the same time, having passion to your profession. Thank you very much.